Dr. Fache.
All right. Okay. Thank you, Cynthia. So I'm just going to fast forward to the fact that the female ovary, for every woman that lives long enough, gets to a point where it is thought that the eggs are exhausted. The store of eggs are exhausted, and that is when women go into menopause. We know as well that at this point, where most women go into menopause, there are still some eggs, few eggs, about 1,000 eggs or thereabouts, that are left in the ovary. And those eggs, apparently do not actively mature. So they are just dormant and they are there. So prior to this time, they're just there, and eventually they are not used up. So in 2016, like I said, before then, of course, PRP, which is platelet-rich plasma, had been used in several fields of medicine for regenerative purposes, right from 1987 when it was first used, in heart surgeries. And since then, it has found application in several fields of medicine, like cosmetics, aesthetics, orthopedics, people who have baldness, people who want to rejuvenate their skin, people who have degenerative diseases of the bones and muscles. So these have found application. But in 2016, kind of is the first time when it was presented in a scientific gathering that yes, you can also apply this PRP to the ovaries, and then it would help to reactivate. So that's the essence of rejuvenation, reawakening something that is old, and so reactivate egg maturation and production by the ovaries in otherwise ovaries that have become exhausted of eggs. So that's the concept of ovarian rejuvenation, and this is quite useful in fertility, where we're having to see a lot of women whose main reason for not being able to conceive is simply because they have advanced in age and they have reached this point where the few eggs left in their ovaries are no longer actively maturing. So this is like a stimulus to activate those eggs. And so that's the concept of ovarian rejuvenation. It was also found along the line, for everything they found, there is always a foundation, and then improvement begins to come in along the line that apart from these dormant cells, there are also what we call ovarian stem cells that are also the stem cells are cells, very native cells that can be conditioned to develop into different kinds of other cells in the body. So these ones are in the ovaries, and it is also taught, this is trying to explain the principle on how PRP works to activate these stem cells to develop into the female eggs. And so this can help women that we typically call women with diminished ovarian reserve. These are women who have very few eggs in their ovaries. Like even if you need to stimulate them during IVF, for instance, they don't give you more than 2-3 eggs. Sometimes you don't even find any egg, even when you give them very high doses of medication. It has also found use in women that have what we call premature ovarian insufficiency or ovarian failure. These are women, also, common terms is premature menopause. Women who go into menopause under, less than age 40. We say it's premature menopause. And most of them, over 70% of them, we don't actually know what causes it. We just know that, okay, they no longer have enough eggs in their ovaries. So this ovarian rejuvenation have found use in such a category of women, and most of them actually, one of the cardinal symptoms is that they are not even seeing their menses. Some of them have gone back to resume menses, have regular menses, they have conceived naturally, and when they have to do assisted reproductive technology to get pregnant, their egg yield is a lot better than without ovarian rejuvenation. So this is the concept of ovarian rejuvenation in fertility. Looking on the side of infertility, like I mentioned the last time, effort, from one thing to another, efforts are now going to say, okay, even women who are menopausal, who have severe menopausal symptoms like the hot flushes that is, can be very disturbing, prior to this time would benefit from what we call hormone replacement therapy, which also comes with its own significant side effects. And so they are now comparing ovarian PRP alongside this HRT, which is hormone replacement therapy. And the results are quite encouraging that people can do this ovarian PRP, which is more like a natural therapy now. And then many of them are beginning to have relief from these postmenopausal symptoms. So I think basically that creates a background for ovarian PRP. And I talked about the last time that what we do is what we call plasma that is rich in growth factors, because PRP is platelet-rich plasma. So like some steps for that to be able to extract these growth factors from the platelet, kind of supplement with other growth factors, and then that is what we use for ovarian rejuvenation.
See, before we answer questions, right? As you did, just shooting out my own questions for my own vocabulary.
All right. Okay, that's fine.
Okay, thank you so much, Dr. Fache. Thank you for giving us that brief summary. So, women, you've heard, and ladies and gentlemen, you've heard everything that we said. This is a summary of what was said last week. Now, I'm just going to go straight into the question sessions. I'll start with the previous questions that we had from last week, and then I'll go into this week's questions. Again, I can already see someone's put in a question. If you have a question today, there's a question mark underneath at the bottom of your screen. Please use that question mark to put in your questions. That way we don't lose your questions and they will be answered by the doctor. Click on the question mark and type in your questions, the questions you have today. So, Dr. Fache, for question number 1, says, for someone who is going in for donor IVF, is ovarian rejuvenation therapy necessary?
The answer is no. If you're going to, for donor IVF, then it means that you're trying to, you're getting an egg from a younger person who is thought to have enough eggs and then good quality eggs as well. So in that case, the intending parent is not using her own eggs, and so there will be no need for ovarian rejuvenation. Now, ovarian rejuvenation, the concept is when you get to that point where you're going to either decide to say, okay, I can't have kids because my ovaries, I've run out of eggs, or I don't want to use donor egg, or I want to try something so that donor egg is like a last resort, then that is where ovarian rejuvenation comes in a bid to say, okay, is it possible that I can benefit from this ovarian rejuvenation so I don't have to use donor eggs? So it's not something like, okay, you're using at the same time using donor egg, except of course if you are also looking at instances where you want to say, okay, you want to run concurrent cycles. I want to still try my own and see if I'm going to get a yield. That's like running tandem cycles. Now you're stimulating the the patient and then stimulating a donor, and so you're probably thinking of supplementing the egg yield from the recipient with the donor egg.
Okay. So in a nutshell, it is advisable that if the person is, they can still do ovarian PRP while So they can both be running tandem. They're doing donor egg, or they can try ovarian therapy, whether it's because they are only you.
Absolutely.
They can have their own genetic
babies
at the same time.
Yes.
Yeah. So for the person that asked that question yesterday, I hope that answers your question. A quick one. I see amazing something. Can you please put your question with the question box so that it doesn't disappear too far off the line? Use the question mark and write the question in there so that we don't lose it, because we have quite a few questions to go through. Okay, so someone also wants to know, can someone who has autoimmune diseases or disorders be treated or before going for IVF treatment? Well, that's the exact nature of the question. So someone who has an autoimmune disorder, should they be treated before beginning IVF treatments, or can certain treatments like ovarian PRP be done on people with autoimmune disorders?
Yes, PRP can be done in people with autoimmune disorders. In the aspect of regenerative medicine, PRP has also been used to treat or ameliorate the condition of some autoimmune disorders. Now, when it comes to recurrent implantation failure, autoimmune disorders are, one of the conditions that actually is responsible for recurrent implantation failure. So it is important, if somebody has autoimmune condition, for that condition to be treated before you go on to have IVF. And that's one of the reasons you see us doing antiphospholipid test, antibody testing, to find, especially in women that have had recurrent implantation failure or recurrent miscarriages, to find out if any of this is responsible. So it is important, if you diagnose someone with autoimmune condition, to control it or treat it before embarking on IVF.
Someone here says, can a 39-year-old with one blocked tube, fibroids and polyps get pregnant, or does she naturally, or does she have to go through IVF or any treatment?
I think this is where we get things mixed up. This person has listed about 3 conditions that independently can prevent pregnancy. IVF is not a special pregnancy. The womb, as it were, serves like the soil. If a good farmer is going to be planting, there are 2 main things that must be in place. The farmer, first of all, wants to get a very good land, arid land to use, and then get good quality seeds. So when it comes to IVF, the embryo that we're transferring is the seed, and then the womb is that soil. So even if you get the best of seeds, that's best embryo, and you put it in a defective uterus, there cannot be implantation. And so if you have fibroids, the type that can affect implantation, even if that is the only thing you have, you can't, IVF will not be successful. Then if you have polyp as well, and then it's large enough, it can prevent implantation. Without implantation, there is no pregnancy. If you have one blocked tube, if it's just a blocked tube, yes, it is possible for the other tube to help the woman conceive. But then there are instances where that blocked tube can also be so damaged as it contains, maybe it could contain fluid, what we call hydrosalpinx, and that fluid may be toxic. So depending on how badly damaged this blocked tube is, it can also affect implantation. And like implantation is a central process which heralds the beginning of pregnancy. So these are all independent. So you match the 3 of them and expect to be pregnant. I don't want to play God, but it's almost like impossible at that point. So if these conditions need to be sorted, because whether the pregnancy is going to be conceived naturally or IVF, all of them would implant in the uterus. And if you have this condition, you need to sort it out. Now, the person has also put an age 39. When a woman crosses age 35, the decline in ovarian activity is so rapid that by age 40, they are already naturally entering into that category of people with diminished ovarian reserve. So when we see, that's why when we're talking about infertility, we now classify when to seek help based on age. And we say, okay, those who are 34 and below can try for 1 year before seeking help. If you are 35, then 6 months, 35 and up to 39, 6 months of trial, then you start seeing your fertility specialist. And if you are 40, almost as soon as you're getting married, you should be talking with your fertility specialist. That is because of the influence of age on fertility. So what it means is, when we see people, somebody who is 39, we're not going to be telling you to go and, especially now you have blocked tube, you have fibroid, you have polyp. Now it's okay, go and spend 1 year, 2 years to be trying naturally first before seeking help. So these are people we counsel to say you need to hit the ground running. So because of age-related decline in fertility. Somebody who is 25, for instance, maybe 28, 30, we can say, okay, but these are individual, independent problems. So when you put them together, it just makes it look like, hey, this is going to be difficult for this person to conceive without sorting those problems out.
Mm-hmm. So for this person, you need to quickly attend to all of those underlying issues.
No, absolutely.
Except, of course, the preferred, I'm guessing, except the person is going to use a surrogate, which case they don't need to.
Absolutely, yes. Yeah, that's correct. That's correct. So if you find yourself in that situation and for some reason either you are not fit or you have aversion to surgery or something, then you can as well just opt to have a surrogate or a gestation carrier help you carry your pregnancy. Yes, baby, provided that the egg is coming from you and your husband, sperm from your husband, then it becomes, that's your genetic baby, then a gestational carrier would help you to carry. But then if this person wastes a lot of time and start procrastinating, then you now add that effect of age again. So blocked tube, fibroid, polyp, then you now add age-related factor. Then it's going to be like using donor egg and then using surrogate.
Age-related premature, ovarian depletion of your ovarian reserves. You remember when I first came to you, I think I was 33 at the time. Mm-hmm. I was 33 at the time, and everything was hunky-dory. But of course, with all of the different IVF, it's traumatizing. Mm-hmm. So for me, I used to take out the whole years I get my power back. Mm-hmm. But what we then discovered is that with each of those years that I'm taking off, your body is walking behind the clock.
Absolutely.
Mm-hmm. Is not what your body is deciding to handle. So with things like this, it's very important to note that time is good, and as well as we need to know that and act accordingly to save ourselves from pain further down the line. Okay, someone wants to know, what are the side effects of ovarian rejuvenation? I believe you covered that day, but just
the main substrate in ovarian rejuvenation, which is the platelet-rich plasma, is from the patient's own blood, and that actually has made this PRP a very safe application. We call it autologous PRP, meaning that it is from the patient's own blood. So it's short of saying that, there are no side effects, but when it comes to injecting this into the ovaries, you would know that, a needle is passed into someone's abdomen, to assess the ovary. So there's going to be some degree of cramping. There may be spotting, even though we're not working directly in the uterus. And then, of course, usually lower abdominal cramps that respond to simple analgesics. Occasional, maybe mild infection relating to the process now, so which emphasizes the need to do it under strict aseptic condition. So this is done in a very sterile environment. So basically, if it's done, if there are accidents, then sometimes some patients can bleed, or maybe there are challenges, which is what we try to do to, like, okay, ensure that you can see the ovaries clearly before attempting to go and inject something into them. If you're not seeing clearly, or you're not using high resolution ultrasound, then you can, person can go into a major vessel, and then of course that becomes a significant complication. So these are all things that we try to mitigate when people go in for initial evaluation. All this is ascertained. Ovaries are clearly seen. If they are not seen, you'll be told, and then to mitigate against any form of serious complication. Other than that, ovarian PRP, because considering the fact that it's from the patient, is generally safe and well-tolerated procedure.
What you've just said pretty much really underscores the fact that people need to do their research before they go in. I know for a few people you've heard of PRP, use it in cosmetics, and all of that. So you think it's now these are your ovaries. Even when women have hysterectomies, they tell you to leave the ovaries intact, because tampering with your ovaries can literally destroy your life as you know it. This underscores the fact that it's exceptionally important that when you're going in for a procedure like this, you're going into a place that is reputable and has the right kind of equipment, because it's not just about the PRP, it's also about the injecting aspect and all of that. And I remember Dr. Fache mentioned last week Wednesday that there's no one-size-fits-all approach to this. Everyone has something different about their own.
Yeah, absolutely.
Okay. Quickly, Dr. Fache, I wanted to ask you a question, just an addendum to this, even though this is not personal. What if someone had the tendency to have, or what do you call it, where you like what I had, where you produce a lot of follicles, hyperstimulation.
Ovarian hyperstimulation syndrome.
Yeah. What if you have that, and then, because, for instance, in my case, we didn't know that I didn't present any prior symptoms of someone that would be having. So what if there's someone like me who then comes in for ovarian PRP? How could that potentially affect that situation?
Ovarian hyperstimulation syndrome is something that is almost exclusively associated with fertility treatment, where you have to do ovarian stimulation first and foremost. And for the category of patients that we're talking about, ovarian PRP, they are most unlikely to develop ovarian hyperstimulation, because ovarian hyperstimulation is something that is almost exclusively associated with people who have many follicles in their ovaries. So, it's not something you would find in women who have very little quantity of follicles in their ovaries.
So I just want to quickly jump into, before we go back to last week's questions, I want to treat some of the questions from today, just so that let me not say it, so that I don't jinx it when I move people. Okay, so the first question I have here is, hold on. The first question I have here is the procedure painful? I think you answered this, but I believe you said the pain can be dealt with
Yes, no, not general. I mean, it's a procedure that is done under conscious sedation, simple sedation. So simple. I mean, talk about analgesia like paracetamol, simple analgesics.
Let me jump into some of the questions that we have today. Okay, so we've answered the question of whether the procedure is painful or not. And then someone here says, an interesting session you've got, and we've learned a lot. My question is for Dr. Fache. Has he recorded many successes after doing ovarian rejuvenation for fertility? I am a 39-year-old woman with low ovarian reserve and egg quality.
I mean, we can't say many successes, but we have recorded some successes in terms of a few patients, are pregnant, and then we're seeing improvement in the baseline parameters that we are using to record improvement in ovarian reserve. Now, mind you that this is a procedure that we just started doing sometimes in July, August, and so we haven't had that large number to say, okay, many successes. So, but then we're recording successes. We also let patients know that there is this, there's still an experimental aspect of this whole process, and so we're unable to determine ab initio who is going to benefit and who is not going to benefit. Of course, we have exclusion criteria, like the person who asked about having fibroid polyp and those kind of, if you have that kind of condition, we are likely going to exclude you from the ovarian rejuvenation, because ultimately, even if the rejuvenation works, you're not going to be able to get pregnant. And what people are just going to say is, oh, I did rejuvenation, it didn't work, I didn't get pregnant. So one of the things we do is we try to screen patients for fertility generally and ensure that there are no other factors that are standing against conception. If there are, we would advise the patient to sort them out, so that, because the end result we're looking for, especially when it is done for fertility purpose, which is that's the indication we're seeing so far. We haven't seen somebody coming to do it for like, oh, I just want to relieve my symptom in our center. But of course, from literature, we're seeing that, some centers in the US, in Greece especially, are already offering this ovarian rejuvenation for that purpose. So from our end, we feel that it is something worthwhile trying, and we try to put it side by side with the fact that many women who find themselves in this situation are doing a lot of supplements, for instance, most of them that are quite expensive, and there is no certification that these supplements are effective, but they're just used to, out of nothing to do, go into the pharmacy. They are ordering online. When they travel, they go into pharmacies to buy these several supplements, and many a times it doesn't even confer any advantage. So when you put ovarian rejuvenation side by side with just those supplements, for instance, we would advise patients to try ovarian rejuvenation, because many of these supplements at the end of the day do not work. The other reason that some of them are not working is most women do not really subject themselves to assessment. So a lot of times they're just going to buy supplement. If you have blocked tubes, for instance, supplement will not help you conceive. If you have uterine fibroid, the type that can stand on your way of getting pregnant, supplements will not help you conceive. If your husband has semen abnormalities and you are taking supplement on his behalf, then you cannot conceive. So I think it is fundamental for women who have challenges with conception to, first of all, subject themselves to proper assessment, and then know what is wrong with them, and then seek counsel on how can these things be tackled instead of just, okay, moving from one supplement to another, moving from one hospital to another, without really recognizing the fundamental reason why you're unable to conceive.
Thank you, Dr. Fache. Thank you for that response. Okay, so, okay, no, sorry, that one. The next one we're going to deal with is how many sessions of ovarian rejuvenation can one undergo?
Typically, for between 1 and 3 sessions. But what we do, usually is, do the first one and then assess response. If there is response and we consider that is suboptimal, then we can encourage the patient to have additional sessions. And so these sessions can be done monthly for a total of 3 sessions. They can be done, 2 monthly, for a total of 2 sessions. So you can also decide to have just 1. You can have 2. Of course, if you have 1 and it's it's beneficial, then it's not something like, oh, I had 1 is beneficial, let me have 2 so that it's more beneficial. Most of the time, we're actually doing additional session if there has not been an observable improvement or benefit from the first one. So it's not something like, okay, if I do 1 and I'm getting benefit, then let me do 3 so that the benefit can be times 3. So most of the time it's like, okay, 1 didn't seem to have much benefit, and so, okay, let's try again a second one and see. So that's how it is for now, but usually between 1 and 3 sessions.
So between 1 to 3 sessions. Thank you for that response. Okay. Is ovarian rejuvenation good for women with PCOS?
I mentioned in my last session that for now, before we started using PRP in the ovary, PRP has been used in gynecology, especially more in the aspect of cosmetic gynecology. Then it started to be used in endometrial rejuvenation. That is the lining of the womb now, where there has been some damage, maybe from intrauterine adhesions, or maybe for some reason, some women whose linings do not really grow thick enough during IVF treatment. So this PRP had been used in that regard for endometrial rejuvenation. And then it started to be used for ovarian rejuvenation. There is not so much literature yet about women with PCOS. So it is possible, like I said, the people who came out in 2016 to say, okay, this is what we have been doing, and this, they started from somewhere, probably get their patient's consent to administer this to them, and then they saw the benefit and came to tell the whole world that this is what they were doing. It is possible that, silently, people are doing this in their centers. What is key is letting patients know what you're doing, and then if it's experimental, let them understand that, okay, this is experimental, and then get their consent, especially if you're able to convince them that it doesn't have any significant untoward side effects, so that's how data gets, we gather data in science or in medicine. So when you have applied it to a significant number of patients, you can see the effect, then you can come out to tell people to say, okay, this is what you've done, and so this is the result. So for now, you cannot unequivocally say, okay, this is beneficial to women with PCOS.
Okay. But we try and then observe.
Absolutely.
Because it's still research. Yes. How long does it take for one to do IVF after undergoing ovarian rejuvenation?
Yes, if you look at the period that it takes for the egg to mature from a dormant egg to what we call the primordial follicle now, to the pre-ovulatory. That I mean, this is medical now. The process of maturation. So, you know, so that process of maturation takes an average of 8 to 12 weeks. So, and that is what we know that even in the ovaries, you have different eggs and different, it's just like you find maybe let's assume all girls school, for instance, where you would have somebody in kindergarten, nursery school, primary, secondary, and maybe university. So there are going to be people at different stages, all in the same environment. So that's what happens when you look at the egg. Yes, if you take a typical egg and say, okay, how long will it take this egg to start from the primordial follicle to the pre-ovulatory? It might take an average of 3 months, but we know that there are some that are already have left that dormant phase and they are already in the process. So usually when we do ovarian rejuvenation, we're looking at running, the fertility treatment like stimulation, for instance, within 3 months of the rejuvenation. That's when we feel that you can get the best benefit from the treatment.
Thank you. So this answer this particular question, but we have one school as well, so no need to get into that anymore. And then there's this one that says, can PRP help uterus prolapse?
Now, uterine prolapse, it comes in degrees. Like there is, first degree when there's just a small descent, and then you can notice that, okay, the cervix has descended a bit into the vagina. Then you have the second degree where you can actually feel the cervix at the level of the external, vulva now. And then the third degree where it's actually coming out, and of course you have the fourth where the whole uterus, it's out of the vagina, what we call procedentia. There are symptoms that also, this is what we will call them pelvic relaxation. And like I said, this is one of the aspects that PRP had been applied in gynecology, what we call urogynecology, to help symptoms that get associated with this, like incontinence, urinary incontinence, different forms of incontinence get because of the association between the urethra now, which is where the female urine comes out, and then the uterus, their support. So when the uterus begins to lose its support, that definitely would affect the bladder and the urethra. And so PRP had been used as well to strengthen this support. It may not reverse like the descent, but it can improve significantly some of these symptoms, especially in the early phase of the descent. And so people have had, their stress incontinence, for instance, improved or treated with PRP injection. These are aspects of urogynecology or cosmetic gynecology, which are also, services that we offer. So again, one size does not fit all, so you need to be assessed to know the degree of uterine prolapse, and then you would know whether this will be beneficial or you may need to have surgery. Even sometimes when people are going to have surgeries, because of the degenerative changes in the surrounding structure, PRP may serve as an adjuvant, like something to support away from, okay, not only surgery. Now you have surgery, and then we're supporting the treatment with PRP so you can get better outcome.
Is this procedure can restore monthly periods?
Yes, it can restore monthly periods if the reason for the absence of the period, for instance, is simply decline in ovarian activity. Now, if somebody somebody had asked about, PCOS, for instance, and I have said that we cannot ascertain the benefit of PRP in PCOS, for instance. So, if the reason why somebody's monthly cycle is not coming is because of PCOS, then I cannot. It's not likely that PRP will restore that monthly cycle. If there is some form of damage in the uterus, and then there is absence of menses or scanty menses, except if you are doing endometrial rejuvenation, then ovarian PRP is not likely to restore that monthly period. So, but if it's which is what you have in women who either have premature ovarian failure or premature menopause, or people who are actually premenopausal or have just attained menopause. It's not like somebody who is 10 years postmenopausal now is coming to say, oh, let me have PRP, ovarian rejuvenation, so I can start seeing my period every month. Period is something that revolves around eggs in the ovaries, and that is what gets exhausted when women go into menopause. So and that is where ovarian rejuvenation comes. So if your ovarian rejuvenation is successful, then yes, you can have a restoration of your monthly cycles. I hope that answers the person's question.
Yes, I believe it does. And the person that was asking about the uterine prolapse actually said it's first degree prolapse, uterine prolapse.
Yes, if it's first degree, as you can have some improvement with PRP, not ovarian now. PRP injected into the tissues, vaginal tissues, and then the ligaments. You know that when you hear things like O short, P short, all those are things that you use PRP for. O short is like orgasm short. These are things that we're doing based on cosmetic gynecology to improve the female sexual response. So that's another aspect entirely. I hope in the future we'll have opportunity, because it's a different ball game entirely when it comes to cosmetic gynecology. Most times when women have given birth and they are getting into this age as well, all their pelvic organs are getting weak. Even the private parts, also gets affected. So PRP is able to rejuvenate those tissues. And so we found usefulness for PRP in increasing vaginal lubrication, female sexual response, and then female orgasm and the rest of them. So hopefully we'll find time to discuss this as well, so people can actually, like I said, PRP is quite versatile, and there is a lot of usage in gynecology these days.
I was going to ask, talking about cosmetic gynecology, sorry, before I swing back into last week's questions, I noticed a trend of basic aesthetic, like facial estheticians, dermatologists, offering O shots. I don't know, because that is, in my mind, a gynecological procedure, albeit cosmetic gynecology. But I believe that in medicine there are specializations in different places. So to what extent, I don't know if it's right to be asking you as their colleague this question, but to what extent is safe, so to speak, for an esthetician to be administering cosmetic gynecological procedures?
Gynecology, as it were, is a special field, and usually I would advise people to use their wisdom to choose, where they go with their problems. Now, if you take your Benz to a motorcycle repairer, for instance, then whatever you get, you don't blame the mechanic, you probably blame yourself in the end. So it's not an area I would want to comment, but I think it's just for people to understand that I mean, if you haven't learned the anatomy of a particular area, for instance, going to inject things because you can inject it on the scalp or you can inject it on the face is not the same thing as going down there. So, and people need to put a distinction between what you're getting from your esthetician, as it were, and what you're getting from your gynecologist.
To be honest, I also say, in a way, it's also down to an issue of lack of public awareness. Because I, for one, apart from today's session, did not really consider cosmetic gynecology, and the people that push this procedure happen to be the estheticians. So it was just speaking today that, making me connect the two dots. However, I feel like our able OBGYNs, gynecologists, and all of that could do better in pushing awareness of cosmetic gynecological procedures, so people are not going to plastic surgeons, for instance, for vaginal reconstruction and all of that stuff. I know it's not something that is pushed as well as it should from the experts like yourself, but just saying, I think there should be more awareness.
Yeah, so like I mean, this whole educational thing was something you kind of facilitated to say, okay, oh, someone has spoken to you about it, somebody benefited, Dr. Fache, come and educate. There is something about medicine and this other profession. Medicine is a highly restricted field. So, I mean, as much as possible, I mean, people need to be seen as not, I mean, like self-advertisement. So you can't just come out and say, oh, we do this, we do that, we do that. So that's why, I mean, when these opportunities come to educate the public, then people can get to understand that, oh, this aspect is actually is available. There are a lot of services, including laser, like vaginal rejuvenation, for instance, that we offer, but you can't just come to the screen as, okay, I'm Dr. Fache, MD of Procare. This is 1, 2, 3, 4, 5, 6 things that we're doing in our hospital. So we also expect people to do their research, or maybe when we have this opportunity to educate the public, and then they get to know that, oh, I mean, especially the aspect of cosmetic gynecology, even, I mean, as common as infertility, most women find it difficult to sit in front of their doctor and simply come out straight and say, I am finding it difficult to conceive. They will start from something is moving in their tummy, how they were born, maybe in the hospital, how they tie their placenta, and something. So, I mean, they just go through, and I mean, the one that actually sometimes I used to tell women is, when you go to, I mean, a hospital and you say, I'm having irregular menses, for instance, my menses is not regular. Now, if you meet a young doctor who is not experienced, the first thing that comes to his mind is probably to give you a family planning pill to regulate your period. And meanwhile, this person would not know that this woman who is coming from the angle of a regular period, to her, once the menses is regularized, then she will get pregnant. And so this guy gives family planning pill. So you're seeing your period every 28 days, but you're never going to get pregnant. So, I mean, this is how hard. So a woman is not going to, it's not going to be easy for a woman to come and say, I don't enjoy intercourse with my husband or something. I haven't experienced this before. Or maybe when I try to laugh, there's a spot of urine coming out. So again, it's an aspect that we need to begin to actually enlighten women so they know that there are treatments available. These are conditions that you could get treated in a hospital, and sometimes you may not necessarily have to undergo surgery to have them corrected or improved upon.
Dr. Fache, I can see that I'm going to have you back here again for my women, because on this matter of cosmetic gynecology, I don't know what you're talking about, but most women want to make it happen, but the thing is, they're going to the wrong place. So it's even good that this happened to come out now. And what I was trying to tell you about doing things from before, men, you like it when we go straight to the point. Women don't think like that, and don't communicate like that. So please do push it there with us. And women too, as you have heard from the doctor, going around the bush can lead you to misdiagnosis. So please, just go straight to the point and hit the nail on the head when you're in front of the doctor. Especially when it's a male doctor that cannot understand you like the women can.
Absolutely.
So if you don't have your ability when you're presenting something to your husband and you are hitting the nail on the head first, use that approach when you're hitting the nail guy. Okay, Dr. Fache, let's move on quickly. We have about 20 minutes left. I promise you I wasn't going to keep you late.
Absolutely, yeah, thank you.
Yeah. So, there's a question here. Will it help to improve ovarian care help to improve the chances of conception through IVF for a 48-year-old woman? Or will it help to improve her chances for natural conception? I mean, we talked about this quite a bit, so I think your response to this can be quite...
Anyway, currently we put age limit for ovarian rejuvenation at 50 years. And we also know that there is a bit of difference between natural conception, where, like we said, one egg starts the journey and possibly may get fertilized. So if a woman has ovarian rejuvenation and she is lucky to have positive response, there is an increase in her ovarian reserve. Yes, it can increase her chances of natural conception if that is the only reason why she's not able to conceive. And in the same vein, can improve her ovarian response to stimulation during IVF. So both ways, it is something worthwhile to try, whether you're expecting to conceive naturally or you're trying to do IVF at that age. Currently, that's one of the ages that we just usually we tell women you don't need to try, just go and use a donor. Like in the UK, for instance, once you hit 45 and above, they are not just going to be discussing own egg IVF with you. They're going to tell you outrightly, go and try donor, and that is for good reason. So when you're going to be doing IVF at that age, even if you respond to ovarian rejuvenation, you need to know that the embryos are going to, it's advisable to have what we call pre-implantation genetic testing of the embryos, just to exclude the possibility of chromosomal abnormalities in those embryos before putting them back. And and then you also have to do what we call embryo banking, meaning that you need to prepare to run multiple cycles and then bank embryos that you're getting from each cycle, test them for genetic or chromosomal abnormalities before transferring them back.
Is this something that is done in the full range of the services in Nigeria?
Yeah, absolutely, yes. Yes, I mean, it's these are things that we do, and I think there are other few hospitals that offer what we call pre-implantation genetic testing. If you are of advanced age, the only thing is, I mean, of course, when it comparing to the regular IVF, it's the cost, difference is much when you need to do this genetic testing on the embryos before transferring them back into the woman. And it helps a lot because you don't want to, having gone through the challenge of trying to conceive and then eventually you have a baby, rather than being a source of joy. It's not all babies that are source of joy. Some are source of problems, and then you are beginning to look back to say, oh, how did I get myself here? Yeah.
Okay. You answered this question or something similar to this question last time, but I'll just throw it out there to you again. Can it be used for men with azoospermia or oligospermia?
Oh, okay. Yeah, I think yes, we actually answered it in the last session, but then it's still the same thing, similar to polycystic ovary syndrome. That there has not been so much, experience with using it for this condition. Azoospermia is complete absence of sperm in a man's semen, and oligo is when there is a reduced below normal level of sperm in the man's semen. And like I told you, because of the versatility of PRP, people are going to be applying it in different places. What is most important is whatever you're going to do with PRP, please inform your patient. Let them understand that this is something you want to try. Maybe, especially where there has not been evidence to support it. And if just like people, like I said, people go to buy supplements. So if they feel like, some would come to you and say, okay, we just want to try it and see. So if they understand it, I suspect that people are gradually trying this elsewhere, and then eventually we're going to be having data coming out in the near future about, okay, use of this in PCOS, use of this in endometriosis, use of this in azoospermia. So it's very versatile. And so it's being applied. Even ophthalmologists are using it in the eye. So there are different places where this PRP is being applied. And so in the near future, is going to, evidence is going, we're going to see more research work on this aspect.
Can a diabetic patient do ovarian PRP?
Yes, diabetic patient, diabetes is, what is important is you get your diabetes controlled first and foremost, because for everybody that is trying to get pregnant, we have what we call pre-conception care, which emphasizes being in a well state before conception. And so if you have diabetes, ensure that your diabetes is well controlled, and then you can benefit from ovarian rejuvenation just like every other person would benefit from it.
Someone here asked, is it a permanent treatment or is it a continuous treatment? I think to an extent you've answered that, but Dr. Fache?
Yes, can you hear me?
Yes, I can.
Oh, okay, yeah. No, it's not. It's not permanent. Like we said, when you give this, do this rejuvenation, and it helps to, recruit eggs that are possibly sleeping. These eggs eventually, can be exhausted. So when the egg is exhausted, then your PRP will not work anymore, because you're trying to stimulate what is there. And then, like I also mentioned, that you tend to see best benefit within 3 months of administration. And so it's not something like you do today and then it's okay, go here forever young. So it's something you do and set a timeline for you to achieve the best benefit from it. So it's not a permanent That book looks scary. Mm-hmm. Mm-hmm.
Earlier on, when we were talking, you talked about ovarian PRP being used as a replacement for hormone replacement therapy or used side by side and showing better results. Now, my question to you is, assuming a woman who is premenopausal or just entering menopause and all of that wants to use ovarian PRP as a means of alleviating her symptoms, right? To what extent? I'm guessing, I don't know what hormone replacement therapy is, but to what extent is this something that she's going to have to be doing like every 3 months? What if it restarts her period? Her period can't be there forever. So to what extent is it actually a permanent solution to the inconveniences of approaching menopause and early menopause?
In that instance, it's something that may require, being administered like every 3 months interval. But then, even menopausal symptoms have periods where, it can be very disturbing, and eventually the women get used to it, and then it tends to just subside. So it's not like, everybody who is menopausal for the rest of their life, 20, 30 years, they're going to be having these extreme symptoms. They have, periods. So it's something that can help ameliorate their symptoms during that difficult time when the symptoms, it's like just transiting from someone whose ovaries were quite active, was secreting estrogen and progesterone, have suddenly that's why naturally the menopausal transition, it goes through a transition phase. You don't just wake up one morning like, I'm menstruating, I've stopped menstruating. There's what we call the climacteric or the perimenopause, which is like the transition phase from normal response to eventual cessation, which is the menopause itself. And that is a period of adaptation that allows you to adapt to the symptoms gradually, so you don't feel suddenly, from good to bad. It's just the same thing with, like I would explain to women, when you say, okay, it seems as if induction of labor, induced labor is more painful than natural labor. And say, yes, natural labor starts and go through a transition, contraction that starts small, and eventually becomes strong. So that period allows you to adapt to the intensity of contraction. When you do labor induction, it's just like from 0 to 100. And so the pain, it seems as if the pain is more intense because you didn't have any period to adapt. So ovarian rejuvenation is ideal for this patient, and like we said, it may not work for everybody, and so it's not something like, okay, it's going to knock out hormone replacement therapy. It's just, something that is worth trying, and if it's like a natural regimen. So if it works for you, you get the benefit. If it doesn't work, then you still have to go to hormone replacement therapy.
Okay, thank you for that. I'm going to ask you one final question. I still have quite a few questions here, but I feel like you answered them along the line, so I'm going to give them a skip. The last question that I have for you here is, how does it help if someone has complex ovarian cysts?
If someone has complex ovarian cysts, then first of all, you would need to evaluate what kind of cyst. In current obstetric, gynecological balance, we were trying to shy away from that term, complex ovarian cyst, because in the end, it really means nothing. There are some functional functional cysts and cysts that form, as a result of the regular menstrual cycle of the woman, and some of them can appear to have different components, and so someone can scan you along the street and describe it as complex. So in gynecological ultrasound now, we are moving away from this using this descriptive term of complex ovarian cyst, because the complex thing you're describing, like hemorrhagic cyst, for instance, is a functional cyst that if you give it time will disappear on its own. It can be interpreted as a complex ovarian cyst. So the first thing first is have a proper gynecological sonologist. That means somebody who is a gynecologist and is also very proficient in gynecological ultrasound to help define what kind of cyst this is, and if it is an abnormal cyst, like an endometriotic cyst, for instance, which is cyst arising as a result of endometriosis, then the person would require surgery to solve, to treat that complex cyst. If it turns out that the cyst is maybe a hemorrhagic cyst, then you can be counseled to adopt what we call expectant management. Monitor. If it's not causing symptoms, go and wait. Come again in 4 weeks. Let us scan and see whether it has resolved on its own. But in that regard, ovarian PRP would not be useful at this current time. There has not been any documentation that ovarian PRP helps with ovarian cyst, whether it is simple cyst or complex cyst.
Thank you so much, Dr. Fache.
Thank you. Pleasure.